neuroradiology session on hypomyelinating disorders. As we all know, hypomyelination results from substantial deficit in the myelin deposition in the brain. And hypomyelination has been observed and described in many genetic disorders. These disorders often have an overlapping clinical phenotypes. So hence radiological pattern recognition often helps the clinician to establish an early diagnosis and management. So in today's session, we will learn the pattern recognition of few of the hypomyelinating disorders. I would like to welcome the moderators of our today's session, Dr. Ramesh Konangi and Dr. Nihal Reddy. Sneha, can you please project the CV slide? Dr. Ramesh Konangi doesn't require any introduction in this crowd. He is the consultant pediatric neurologist from Rainbow Children Hospital, Hyderabad. He has several publications in the national and international index journals, and his fields of interest are neonatal neurology, stroke, neuromuscular disorders, epilepsy, and neurodevelopmental disorders. He is an excellent teacher who teaches the complex neurology topics in a very simplified way. And another moderator of this session is Dr. Nihal Reddy. He is a consultant pediatric neuroradiologist from Rainbow Children Hospital and Tenet Diagnostics, Hyderabad. He has done his pediatric radiology and neuroradiology fellowship from the Royal Children's Hospital, Melbourne, Australia. Sneha, can you project the slide, please? And he has done his postdoc pediatric neuroradiology fellowship from the Johns Hopkins Hospital, USA. He is the program coordinator for the International Pediatric Neuroradiology Teaching Network, and he is the moderator for Pan-India Pediatric Neuroscience Sessions. He is also core committee member for the seminars in the Pediatric Neuroimaging, the SPIN Academy. So over to Dr. Ramesh.
Yeah, good evening, everyone. Thank you for that introduction. So this 1 hour session will be primarily on the neuroradiological aspects of hypomyelinating disorders with a very brief clinical description and main focus being on the radiology part. So we can start with, we have 4 pediatric neurology fellows from Rainbow Hospital who will be presenting 4 cases and 1 companion case with similar radiological features. So Dr. Geeta, you can start with the first case.
Yes, good evening, everyone. We will be discussing the 4 cases, like 4 of us, and after discussing the MRIs, we shall be asking the audience for their any inputs or anything, and they can type in the chat box. So the first case, here is a 6-month-old male child born to non-consanguineous parents and had no significant antenatal or perinatal issues. And this child presented to us with developmental delay, with no neck holding, but response to sound was present and doesn't reach for octaves. This child never had any seizures. And there was a past history of recurrent vomitings and noisy breathing at around 40 days of life. And he was requiring frequent admissions for that. So his weight and head circumference in the normal centiles, AF was open-ended level. There was no dysmorphism and no neurocutaneous markers. And extraocular movements, he had a pendular nystagmus and there was no tracking or fixation. Tone examination, there was generalized hypotonia with mild gastrocnemius spasticity was there, and DTRs were normal, suggesting a central hypotonia. And also there was good anti-gravity movements. So based on the clinical details of this global developmental delay, nystagmus and central hypotonia, and taking the age into consideration, the first differential diagnosis like we would think of was a hypomyelination disorder. So with this, the first investigation of choice would be an MRI, and this child presented to us with already an MRI done at 4 months of age. So this is a slide showing the MRI of the index case in the upper row, and at the bottom it is normal MRI at 4 months of age. So if we look at the MRI of this child, there was a diffuse uniform T2 hyperintensities in the supratentorium everywhere, and also Here also deep gray nuclear or normal. So, but whereas in the normal T2 weighted, we can see the plic hyperintensity, like myelination of the plic, which is not seen in our case. So other T2 weighted there were the hyperintensities in the midbrain and also the brainstem. Cerebellum is also present. And with the T1 weighted images, there is a complete in the supratentorium, it is iso-intense. And with T2 coronal also, there was a diffuse hyperintensities were present both in the supratentorium and also the infratentorial region. In SWI, we don't have any evidence of any mineralization or calcification. And DWI images, there is no diffusion restriction noted. Even in the sagittal section, we can appreciate that T2 hyperintensities, and MRS is showing a normal MRS. So with these MRI findings, with the predominantly diffuse cerebral and cerebellar white matter myelination abnormality, and with the brainstem involvement is the main pattern which is seen in this case.
Yeah, any differentials?
Yeah. So the
Okay.
possible differentials are Pelizaeus-Merzbacher light disease and hypomyelination with brainstem and spinal cord involvement, and Pelizaeus-Merzbacher disease and oculodentodigital dysplasia. Audience can just type the correct answer in the chat box. We will be given around some 20 seconds for that.
Okay, Geeta, you can go ahead with B.
Yeah, most of them answered as an option A or B here.
No, many of them have answered C actually.
C.
Sorry, C.
Yeah.
So with these changes, with the diffuse hypomyelination and the brainstem involvement, like what are the supporting and against that? So for the Pelizaeus-Merzbacher light disease, hypomyelination and brainstem hyperintensities are seen, and some may have this NAA peak also, but our case didn't have. And the second one is hypomyelination with brainstem and spinal cord involvement. We see the similar, but there will be an inverted lactate peak will be there in this. And the third one is Pelizaeus-Merzbacher disease, where brainstem is usually not affected. And the fourth one is oculodentodigital dysplasia. Here, same we see diffuse hypomyelination, but there will be T2 hypointensities in the globus pallidus, substantia nigra, and also in the late stages, we see cerebellar atrophy also. So we have certain companion cases, like one of the companion cases, a male child presenting at 11 months of age, and he has this ARS2 mutation, where we see that there is a gross delayed myelination is there overall in the supratentorium, and also the hyperintense brainstem, and also there was a mild cerebral atrophy. The same child at 2 years of age, when the repeat MRI was done, there was a progressive atrophy changes and there was no myelin catch-up, so which is fulfilling the criteria of hypomyelination. In PMD, like it is caused by mutations of PLP1, which is a similar companion case, and this is a classical form which is X-linked recessive seen in boys. In whereas in PMLD, it is caused by GJC2 mutation and it is seen in girls. And here onset is during the birth or in the early infancy, and they typically present with this developmental delay, nystagmus, extrapyramidal symptoms, stridor, and contractures of the extremities. So here progression is relatively rapid, with the death occurring in the early childhood.
Geeta, to comment upon the brainstem. How is it different from PMLD?
In PMLD,
Yeah.
we know, sir.
Just show it on the slide. How is the
Yes.
forms? Yeah. Is it normal?
Yes, sir.
Okay, so that you have to mention, no? Because most of them thought that was PMD. So in
Okay.
PMD, the pawns is really straight.
The next case will be discussed by Dr. Prituja. Sorry. One more companion case is there. That is HBSL, hypomyelination with brainstem and spinal cord involvement. Here also, like we see extensive white matter changes, and here, like, and also posterior limb of the internal capsule hyperintensity, and in MRS we see this lactate peak inversion will be there. And also in the infratentorium, the cerebellar hyperintensities, and also the medial lemniscus, superior cerebellar peduncle, the pyramids of the medulla are involved. And in the spinal cord, we typically see the posterior column and also the lateral column involvement. The case 2 will be discussed by Dr. Prituja.
Geeta, do you have a final diagnosis for the case?
We don't have a final diagnosis, sir, genetic, but based on the
Okay.
clinical and radiological, it mostly fits into the PMLD. Sir.
Good evening, everyone. I'll be discussing the second case. This is a 2-year-old female child born to a non-consanguineous marriage with no perinatal complications and presented at 2 years of age with developmental delay, tightness of bilateral lower limbs, and speech delay. On examination, the head circumference was 44 centimeter, less than the third centile of microcephaly. Social smile was present. There was tracking present. Child was able to walk with support, but toe walking was present, and spasticity was found in all 4 limbs, moreover in the upper limbs. Spine examination was normal. So on the basis of the history, MRI scan was done. This is the T2 image of the patient, which shows T2 hyperintensity in the cerebral white matter. And this arrow demonstrates the reduction or the atrophy of the lentiform nucleus. And there is also hyperdense areas that is present in the basal ganglia. The second image, the second image that we can see shows there is significant cerebellar atrophy. This is the normal MRI of a 2-year-old child, where we can see that there is the basal ganglia, the lentiform nucleus can also be seen, and the cerebellum looks normal. This is the sagittal image of the same child. In this, we can see that there is a reduction in the size of the body of the corpus callosum as compared to a child of 2 years of age. And in the coronal image, we can see that there is significant cerebellar volume loss, but the cerebral volume looks normal. And this is the normal image of the same age group child, which shows the normal cerebellum without any atrophy. This is the T1 images. Again, usually in cases of hypomyelination, the T2 images indicates hyperintensity, whereas the T1 images show isointense areas. So in the T1 image, we can see that there is isointense areas present in the white matter, and there is cerebral atrophy. So this is the summary of the MRI images that had been shown. It showed the T2 hyperintensity, hypomyelinating pattern with T1 isointensity in the cerebral white matter, brainstem tracts, and cerebellar white matter. There was generalized cerebellar atrophy, as shown in the previous images, mild atrophy and T2 hyperintensity of the dorsal basal ganglia, lentiform nuclei more than the globus pallidus, and there is mild thinning of the body of the corpus callosum. So these were the possible differentials. So any answer regarding which could be the most closest diagnosis for the case.
Okay, so I've already answered HABC. We have
Yeah.
C and B. C. C. Okay. Okay, majority have answered between B and C.
Yes, sir. So the possible differentials was the Salah disease, hypomyelination with atrophy of the basal ganglia and cerebellum with the TUB4A mutation, hypomyelination with atrophy of the basal ganglia and cerebellum with UFM1 mutation, Pelizaeus-Merzbacher disease in the late stage, and 5-10 methylene tetrahydrofolate reductase synthase deficiency. On the basis of the imaging, the primary imaging differential was the HEBC with the TUB4A mutation. As shown in the picture, this is the normal basal ganglia. Here in the second image, we can see that there is atrophy of the basal ganglia. And in the second image, where on the fourth image, there is normal cerebellum, whereas in the third picture, we can see that there is atrophy of the cerebellum. So hypomyelination with atrophy of the basal ganglia and cerebellum is the HEBC with TUB4A mutation. So as many of us in the chat box has indicated that UFM1 mutation could also be one of the diagnoses. So our closest imaging differential was the UF1A mutation. And this UF1A mutation was reported by Dr. Lorenzo Pinelli from Italy. So the basic difference of UFM1 mutation and TUB4A mutation is that in this
Maybe you can
MRI
show that on the
image.
next slide.
Sir?
You can show the difference on the next slide. That will be more descriptive.
So in the TUB4A and UFM1A mutation, the hypomyelination, the atrophy of the basal ganglia and cerebellum is the same, but the major difference is in the caudate nucleus. Here we can see that in TUB4A mutation, the caudate nucleus has a normal signal, whereas in TUB4A mutation, there is T2 hyperintensity in the signal of the caudate nucleus and iso-intense or hypo-intense in T1 image of the caudate nucleus. So in this study, it had been reported that the caudate nucleus is atrophied in almost all the cases of the UFM1 mutation, whereas it was normal in majority of the cases with TUB4A mutation. So on the basis of cerebral atrophy and hypomyelination, these were the differential diagnoses. So the clinical exome sequencing was done for this child and TUB4A mutation was seen. And this is a de novo mutation in which the initial development may be normal and the onset can be in infancy up to 3 years of age. It can present with variable severity and it is a progressive disorder. So these are the phenotypes of the mutation, and the arrows indicate the MRI findings in a TUB4A mutation, where we can see there is hypomyelination of the brain white matter, which is diffuse. Leukodystrophy can be seen. There can be there is cerebellar atrophy and basal ganglia atrophy, as seen in our case. Thank you. The next case will be discussed by Dr. Pawan.
Good evening, everybody. This is a 7.5-year-old boy born to consanguineous marriage and presented with gradual regression of milestones noticed from about past 4 years. And initial development till 3 years was normal, and regression was there over the next 4 years. Initially was in motor milestones and then progressed to cognitive regression with presently not able to hold neck, not able to speak. And there's no history of any seizures. History of sibling death at 9 years with similar illness, almost started around the same age, 4 years of age. And on examination, head circumference was 51 centimeters, which is within center. Hypodontia was there, and severe wasting of all limbs, and all forelimb spasticity, lower limbs more than upper limbs, and scissoring of the legs, and bilateral ankle contracture, and moving limbs along the gravity. And DTRs are brisk, and bilateral ankle and patellar clonus with kyphosis. So this is the clinical picture, which is showing dental abnormalities and hypodontia, and there is diffuse wasting and scissoring and bilateral gastrosoleus contractures. So this is the MRI, which is showing brainstem is showing T2 hyperintensities, and there is atrophy of the cerebellum and brainstem, and the thinning of the corpus callosum. And there is also a mild cerebral atrophy, and there are symmetrical T2 hyperintensities in plic, periventricular white matter, and in optic radiation, and some lateral thalami with a mild reduced volume of bilateral thalami. And FLAIR images showing hyperintensities in bilateral periventricular and deep and superficial white matters. So there is also no diffusion restriction. Summary of the MRI findings: there is a moderate cerebellar atrophy with reduced volume of brainstem and corpus callosum, mild cerebral atrophy, T2 hyperintensities in plic, optic radiation, lateral thalami, and with no diffusion restriction. Cerebral atrophy, hypomyelination pattern with cerebellar atrophy, the possible differentials.
I
Can
think
you answer which?
somebody is asking genitalia. What about genitalia?
He's a 7.5-year-old child.
It is normal in this
It's
state.
normal. So yes, yes. So what could be the possible closest differential?
Most of them have answered as E. Some have answered as A. Yeah, majority have answered as E. Go ahead, Tom.
This is a similar case with this is the case we are thinking in terms of most likely a 4H disease, which is hypomyelination, hypodontia, and hypogonadotropic hypogonadism. So this is a similar case, who is a 14-year-old with global developmental delay with progressive spasticity and ataxia since 8 years of age, with all the above findings that I have mentioned. And the MRI is showing dark thalami on both sides, and diffuse hyperintensity of the white matter on T2 weighted images. And basal ganglia also shows some hypointensity, but not very prominent. And orthopantomogram showing features of hypodontia. So 4H leukodystrophy, the typical findings of 4H leukodystrophy is hypomyelination pattern with T2 hypointensity of a dot in the plic, and T2 hypointensity in the ventrolateral thalami, and T2 hypointensity in the optic radiation, and relative hypointensity in the dentate nuclei, and cyst-like lesion, which can be seen in the splenium of the corpus callosum, and diffuse cerebellar atrophy. And the spinal cord also shows T2 weighted hyperintense signal in the spinal cord. Thank you. So the next case will be discussed by Devanand.
Good evening, everyone. My case is of a 6 months-old male child born of non-consanguineous marriage. It was a term baby. AGA birth weight was 2.7 kgs. History of neonatal meningitis, which was treated by antibiotics. Chief complaints at 6 months, they had presented with complaints of developmental delay. On examination, head circumference was 40.5 centimeter, which was microcephaly. AF was at level. Child had horizontal nystagmus. Light tracking was present, but none of the milestones has been achieved. Child had no neck control, no social smile, and there was severe central and axial hypotonia. So these are the MRI images of the child. This is a T1 image which shows white matter is iso-intense here. There is hyperintensity of the bilateral thalamus and the posterior putamen in T1 weighted image. The brainstem and the cerebellar white matter shows normal signal for age. On T2 weighted image, there is homogeneous hyperintensities of the white matter involving the central structures and also of the brainstem and the cerebellar white matter. The sagittal section shows there is thinning of the corpus callosum and the pons appear slightly bulky. On coronal images, there is homogeneous hyperintensity of the supratentorial and infratentorial region. And SWI images was done as T1 images showed some white matter hyperintensities of the bilateral thalamus and the posterior putamen. So to rule out any abnormal mineralization, but SWI showed no blooming. Focus on SWI images seen. So MRI showed there is diffuse delayed myelination, very likely hypomyelination pattern of the cerebral hemispheres, brainstem and cerebellum, bulky pons, reduction in size of the corpus callosum and thalamus, and subtle T1 hyperintensities demonstrated in the bilateral posterior putamen and the thalamus. So the possible differential diagnosis were Polizus-Merzbacher-like disease, or hypomyelination with brainstem and spinal cord involvement, lysosomal or lipid storage disorder, Sala disease, or inherited manganese disorder. So any guess what this could be?
We have C, D, A, B. D is the majority, Sala's disease. Okay.
So this is a genetic report of the child. It is a case of DGS1 mutation, which is a hypomyelinating leukodystrophy type 18. It is a compound heterozygous mutation, and which has been proved. Parental segregation has also proven DGS1 mutation. So this is a companion case. This is another case of same DGS1 mutation, which we had earlier. This case also shows there is homogeneous hyperintensities of the white matter. There is the posterior limb of internal capsule and the ventrolateral thalamus shows hypointensity, and the brainstem shows hyperintensity, and the corpus callosum is also thinned out here, which is similar to our case. So DGS1 is a sphingolipid metabolism enzyme, which is in the last step, it converts dihydroceramide to ceramide. So in absence of this, sphingolipid metabolism is disturbed. There are very few publications regarding DGS1 mutation. These are the images taken from the publications. This image shows there is diffuse hypomyelination. Abnormalities on the thalamus can be seen, and there is progressive volume loss of the corpus callosum and the cerebellum. This second image from another publication which showed there is patchy hyperintensities of the periventricular white matter in the occipital region, and also the thinning of corpus callosum. So this can also present with diffuse hypomyelination and also can present with patchy hyperintensities rather than diffuse myelination. So this imaging are not very typical, but it comes under hypomyelination pattern. So phenotypic correlation shows there is hypomyelinating leukodystrophy, periventricular white matter abnormalities, corpus callosum abnormalities, and thalamic atrophy. Thank you. Can you go to the next slide, please?
Okay. Who's controlling? Geeta or
Yes,
Geeta?
Ryan.
Okay, so we'll just briefly discuss about the normal malnutrition pattern and the approach to the 4 cases. So as you all probably know, the normal malnutrition, it varies upon the T1 weighted sequences and the T2 weighted sequences. So on the T1 weighted sequences, initially in the neonates, the white matter is hypointense, as demonstrated on the first picture on the left, whereas the white matter is hyperintense on the T2 weighted sequences. As the child grows, the white matter changes to isointense and then to hyperintensities. The T1 weighted signal demonstrates earlier myelination, that is around 10 to 12 months. The myelination is almost complete. So the white matter becomes hyperintense in comparison to the gray matter. Whereas on the T2 weighted images, there is a slight myelination lag. In comparison to the T1 weighted images, the T2 weighted images, the white matter should be hypointense. This is around 2 to 2.5 years of age. So there is some delay in the myelination on the T2 weighted sequences. The T1 hyperintensity is predominantly due to the fat content, and T2 is due to the reduction in the water content. Next, Geeta. So myelin. So myelin is primarily found by the oligodendrocytes. If you see on the diagram on the right, this is the axon, and where the myelin, the oligodendrocytes come and wrap around the axon. This takes place around a transverse process, and you can see that the oligodendrocytes grow along the opposite end, and also they wrap around the axons. This takes place along the radial fashion, that is circumferentially, and also along the longitudinal axis. So there is simultaneous longitudinal growth as well as circumferential growth. And the cytoplasmic channels are predominantly responsible for the growth zone, that is the complete formation of the opposite end of the oligodendrocyte projector. And the completely myelinated brain has a 5-layered pattern, which is primarily found by fats. That is, the oligodendrocytes are primarily around 70 to 75% of fats. So hence a completely myelinated brain, the fat signal is usually T1 hyperintense. So the completely myelinated white matter is T1 hyperintensity, demonstrates T1 hyperintensity. The rest of the myelin is formed by proteins. The most common protein is the PLP1 protein that is responsible for the Pelizaeus-Merzbacher disease. The other proteins are major basic protein and myelin oligonucleotide glycoprotein. The main function of the myelin is generation of the action potential or propagation, that is in the form of saltatory conduction. On the images below, you can see that the right is the myelinated white matter, where there is fast and continuous progression of the action potential progression, whereas the unmyelinated white matter, without the binding of the oligodendrocytes, has a slow progression of the action potential. And if we see the bottom picture below, the lipid composition varies from the time frame of the child. So at around 2 months of age, the total lipids are around 28.4%, whereas around 5 years of age, they are around 60%. So this gives the T1 hyperintensity, which is seen in the completely myelinated child. Geeta. So on MRI, when do you term it as hypomyelination? If we have a scan of a child which is less than 1 year, that is if we take it around 6 months, 8 months, or 10 months, and if there is pattern of delayed myelination on the T1 and also on the T2 weighted sequences, we usually ask for a repeated MRI after 6 months. There should be a gap of 6 months if the child has been screened in less than 1 year of age. So after 6 months, if there is improved myelination, we term the scan as delayed myelination. But if there is no improved myelination or there is progressive abnormalities, we term it as primary myelin disorders or secondary myelin loss related disorders. So we need a scan above 12 years with a variation of 6 months to term it as hypomyelination. Otherwise, if it is less than 1 year, we term it as delayed myelination. So this is just a brief pattern of how the myelination takes place. It progresses from the periphery to the center, from the center to the periphery, from back to front, and from the bottom to top. You just want to, you can refer the myelination milestones on with various articles and textbooks, but this is just a milestone pattern recognition. On the T1 weighted images, at around 3 months, the cerebellar white matter should be myelinated. At around 4 months, the splenium of the corpus callosum should be myelinated. At around 6 months, the genu of the corpus callosum should be myelinated. Whereas on the T2-weighted sequences, at 2 months, the dentate hilus should be myelinated, that is demonstrating T2 hypointensities. The pons at around 4 months, splenium at around 6 months, genu at around 8 months, and the anterior limb internal capsule at around 10 months. So these are just some areas which need to be kept in mind while evaluating a child with suspected hypomyelination. So previously, we have categorized white matter disorders or leukodystrophies into 4 subtypes. That is hypomyelinating, which we have discussed in the 4 cases. This is due to lack of myelin deposition. Dysmyelinating term, which is now not commonly used, is deposition of structurally or biochemically abnormal myelin. Demyelinating is the myelin is formed, but the previously normal deposit myelin is damaged. And myelinolytic diseases, that is disorders of myelin vascularization. Next. So in 2017, Vandernapp and Bugiani came with a proposed pathological classification. That is, they evaluated the white matter disorders based on the pathological process findings and the white matter involved. So they classified it into myelin disorders. In myelin disorders, pure hypomyelinating disorders are these 4. Go back, Ina. Then we have demyelinating leukodystrophies. These are the examples. Myelin vascularization due to intramyelinic edema. These are the examples. Astrocytopathies, which primarily affect the astrocytes. Leukoaxonopathies, which are secondary to axonal or neuronal degeneration. Microgliopathies, which affect the microglial cells of the white matter, and leukovasculopathies, which are vascular disorders. So these were the 5 categories which they have tried to categorize in the more of a pathological based classification. Similar to what we have seen in the previous slide. So the oligodendrocytes are the primary structures which form the myelin. So the structures which affect the oligodendrocytes are the primary hypomyelinating disorders, such as the Pelizaeus-Merzbacher disease or PMLD, oculodental dysplasia. Some leukodystrophies can also have primary involvement of the oligodendrocytes, that is MLDs and XALD. The abnormalities primarily affecting the astrocytes are the astrocytopathies. That is the most common example is Alexander's disease and vanishing white matter disease. And the disorders which affect the microglia are the HDLS and the Nasu-Hakula disease. These are examples based on the pathological classification and also the structure which is primarily affected in these disorders. So this is a normal myelinated white matter on various sequences. So this is how it should appear at around 2 years of age. We primarily look at the T2-weighted sequences at this age. So on T2, the white matter should be completely dark. Flare and is slightly hypointense, similar to the T2-weighted sequences. T1, it should be iso or hyperintense. Diffusion and ADC should not demonstrate any signal changes. So again, this is thanks to Harun, contrast of the normal white matter. That is on the left, you see it is completely T2 hypointense, whereas the hypomyelinating disorder demonstrates diffuse hyperintensities. So is it possible to differentiate hypomyelination versus other leukodystrophies? Possibly, yes. So on the left are the hypomyelinating disorders. They usually present the mild homogeneous T2 hyperintensities. And the T1 weighted sequences, they're usually iso to mildly hypointense, sometimes hyper, depending upon the amount of myelin deposit. It is usually diffuse and usually unchanged, or it's progressive over time. So on the bottom is the prototypical case of Pelizaeus-Merzbacher disease. Diffuse T2 hyperintensity, but on the T1 weighted sequences, you can appreciate it is iso to slightly hypointense. Whereas in comparison, the other leukodystrophies or white matter disorders, they have a more prominent T2 hyperintensity, a more prominent T1 and flare hyperintensity. They can be confluent or multifocal. They can change over time, and they can also demonstrate necrosis and cavitation. So the bottom is an example of a vanishing white matter. As you can see, the T2 hyperintensity in comparison to the Pelizaeus-Merzbacher disease is more hyperintense, and it demonstrates T1 hypointensities. So this is usually not seen in the pure hypomyelinating disorders. So case 1, going back to case 1, the primary abnormalities was diffuse hypomyelination with brainstem and cerebellar changes. Next, Geeta. So if we focus on the brainstem abnormality, as hypomyelination is a common theme, there are some disorders which present with different patterns of brainstem hyperintensities. Pelizaeus-Merzbacher disease or like disease usually affects diffusely the pons, but predominantly the pyramidal tracts, the medial lemniscus, and the cerebellar white matter, that is the medial cerebral peduncles. Whereas the 4H leukodystrophy, it demonstrates T2 hypointensities in the medial lemniscus on the top and also the dentate nuclei. HEMS stands for hypomyelination of the early myelinating structures. It has a more patchy involvement of the dorsal pons, the peridentate white matter, and the medulla oblongata is more commonly or predominantly affected. Oculodental digital dysplasia. You can again appreciate the hyperintensities are patchy but have a pattern. On top is the perimeter tracts, which is affected. The cross shape is the pontocerebellar fibers. We have the raphe pontis at the bottom, that is the dorsal aspect, and the middle cerebellar peduncles are also affected. HPSL, again similar to the ODD pattern. You will also see that the inferior cerebellar peduncles, that is the red arrows, are affected. The dentate nucleus and the peridentate white matter is affected. There's relative sparing of the dorsal brainstem. So these can be helpful in differentiating the various hypomyelinating disorders, which also present with brainstem hyperintensities. Case 2 was hypomyelination with cerebellar atrophy, basal ganglia hyperintensity with atrophy and hypoplasia. Case 3 also has some similar imaging findings, such as atrophy of the cerebellum. So we'll discuss hypomyelination with Gita next. Cerebellar atrophy. Okay, this has been discussed by Pituja already, so you can go to the next slide. Okay, so cerebellar atrophy with hypomyelination. How do you differentiate and what are the typical imaging features? Sala's disease is a common differential. They usually present with cerebellar atrophy, not very significant here, but you can see that the interfoliar spaces are widened on the sagittal image. They usually have corpus callosum thinning and diffuse hypomyelinating pattern. On the spectroscopy, you have the elevation of the NAP. This is characteristic. This is not pathognomic, but it is typically seen in Sala's disease. This is due to deposition of the N-acetyl muramic acid. Coming to the next differential is a folate-related disorder, MTFR synthase deficiency. As again, you can see it has cerebellar atrophy on the coronal images. The cerebellar folia are widened, but the basal ganglia is normal, which was abnormal in the TUF4A mutation, normal in terms of volume and normal in terms of signal. Then we have 4H leukodystrophy, which Pawan has already discussed. And the cocaine syndrome, though not a pure hypomyelinating disorder, can have a hypomyelinating pattern and usually has calcification along the deep brain nuclei and is associated with cerebellar atrophy. Yeah, so the calcification is a differential, and obviously the clinical findings are also different as compared to the TUF4A mutation. Case 4, it was again a diffuse hypomyelinating disorder, and the deep brain nuclei, that is the posterior putamen and the thalami, demonstrated subtle T1 hyperintensities. So these are the hypomyelinating disorders with T1 hyperintensities. Some are also demyelinating disorders. As you can see on the top left panel is fucosidosis. The globus pallidus and thalami, the ventrolateral thalami, demonstrate T1 hyperintensity. The T2 sequences, it has a hypomyelinating pattern. So that is one of the differentials for hypomyelinating pattern with T1 hyperintense or T2 hypointense deep brain nuclei. Coming to the middle, GM gangliosidosis. Again, it has a diffusely hypomyelinating pattern. The thalami on the right, on the T1 metal images, are again hyperintense, and on the corresponding sequence on the T2 are hypointense. Basal ganglia characteristically is hyperintense with a patchy hyperintensity. So this is characteristic of GM gangliosidosis. Cocaine, as we have discussed previously, the T1 weighted images, the mineralization demonstrate hyperintensities. Coming down to the oculodentodigital dysplasia, again diffuse hypomyelination, but you have T1 hyperintensities of the globus pallidi and corresponding T2 hypointensities, suggesting some deposition of mineralization over there. Krabbe's disease is not a pure hypomyelinating disorder, but can have hyperintensities of the deep brain nuclei, in particular the ventrolateral thalami. The T1 weighted sequence you can appreciate in comparison to the basal ganglia. The thalamus is hyperintense with corresponding signal changes on the T2 weighted sequences. So these are the differentials for the T1 hyperintensities and hypomyelinating pattern. They're usually seen in storage disorders, some form of storage disorders. This is again published in the hypomyelinating pattern from Vanderknapp and Wack. If you see the flowchart, assuming that there is diffuse hypomyelination, the other structures can help in narrowing down the diagnosis. As we have discussed, on the top is the T2 hypointensity of the globus pallidus, which can demonstrate T1 hyperintensities. So this is seen in fucosidosis. As seen in the images, there is T2 hypointensity of the bilateral globe pallidi and some degree of the thalami. If there is T2 hyperintensity of the basal ganglia, as we have seen in our example in the previous slide, one must think of GM gangliosidosis. If there is T1 hypointensity of the white matter associated with subcortical hyperintensities, one must think also associated with congenital cataracts, one must think of hypomyelination with congenital cataracts. Tourette syndrome, as you have seen in our examples, there is usually cerebellar atrophy. If there is homogeneous T2 hyperintensity of the cerebral white matter without pontine hyperintensity, one must think of Pelizaeus-Merzbacher disease. The gender also should be kept in mind. If there is T2 hyperintensity of the pons with diffuse hypomyelination, one must think of Pelizaeus-Merzbacher-like disease. And in the early cerebellar atrophy, if there is also atrophy of the basal ganglia, one must think of the hypomyelination with atrophy of the basal ganglia and cerebellum pattern. I'll not go into detail of this diagram, but this is a useful publication published, I think, last year by the CMC group and Ghosh group. This article comprehensively describes the different hypomyelitic patterns. And this is just a schematic to represent the various differential diagnoses and possible findings which might help in narrowing the diagnosis. Yeah, thank you.
Thank you very much, Dr. Nihal. That was quite comprehensive. And thanks, Dr. Geeta, Pratyusha, Pawan, and Devangana for presenting the cases. Now, I think that Sangeeta, you can take question and answers.
Thank you, Dr. Nihal, for demystifying the spectrum of hypomyelinating disorders, how to identify the radiological pattern with a systematic approach you have taught us. Thank you so much. And there are only very few questions. How was hypodontia assessed on the X-ray?
If we go back to the OPG, there is usually reduced height of the dentition and usually absence of the dentition. If Geeta can go back to the OPG. Yeah. So if you see the dentition over there, Geeta, if you go to the central teeth, in comparison to the lateral teeth, you see that the crown and the enamel are well formed on the lateral aspects. Whereas the central teeth are demonstrating reduction in the diameter and also reduction in the height. There are also some gaps in the teeth, which is suggestive of hypodontia. So the incisors, the central and lateral incisors are usually demonstrating thinned out appearance in comparison to the teeth on the lateral aspects.
Next question is pons less affected in PMD compared to PMLD, or is it completely spared?
It is less affected. I wouldn't say completely spared. There are cases with PMD having some patchy hyperintensity of the pons, but more diffusely involved in PMLD.
So what is the utility of MRS in hypomyelinating disorders?
Usually only require that maybe for Sala's disease, as someone has pointed out, they usually has an NA peak. Other disorders which can demonstrate an NA peak is Pelizaeus-Merzbacher disease and Pelizaeus-Merzbacher-like disease. So these three diseases can present with the NA peaks, but usually the conventional imaging gives us the clue as what the diagnosis can be. So MRS is usually not required. But in case there is some doubt, if you see an elevated NA peak, then obviously the primary hypomyelinating disorders can demonstrate that. And if there are mitochondrial disorders or mitochondrial leukodystrophies or Canavan's disease, but they can be differentiated on the conventional image itself because they usually have present with diffusion changes or rare factory changes or hypointense changes on T1 and flares. So usually they don't require, but yeah, the mitochondrial disorders and Canavan's disease can demonstrate a lactate peak.
I have a question. In some of these children with near complete absence of myelin, I have seen restricted diffusion throughout the white matter.
Okay.
Any comment on that?
Then that is not a characteristic primary hypomyelinating disorder, because there is some necrosis, something going on there, some energy disruption, which causes the restricted diffusion. So there can be a demyelinating component on the hypomyelination.
Okay, like one of the companion case Geeta had shown, AARS mutations.
Okay.
That
so
child initial scan was showing restricted diffusion, but
Okay.
at 2 years also he still had almost complete absent myelination.
Yeah, so ARS mutation, again, they do not characterize it as a primary hypomyelinating disorder. It comes as a demyelinating and a hypomyelinating mixed type of pattern. So there must be some demyelination going on, which is presented with restricted diffusion.
Okay.
Any thoughts on imaging features of Paul Orvancy hypomyelinating leukodystrophy?
The Pol3B ones are typically what we are shown in the slide. They can present with only the extrapyramidal phenotype, which can have only the basal ganglia and thalamic changes. This one. These are the typical imaging features of the Pol3 spectrum. They can be Pol3-1C, Pol3B, and those related disorders. So again, you have diffuse hypomyelination. The main clues are in the central regions of the brain. They usually have hypointense globus pallidus, some degree in the posterior mental capsule, ventrolateral thalami, and dentate nucleus, and associated with cerebellar atrophy. The splenial cyst is not a very typical finding. Only the magnified images, some cases demonstrate the cystic change in the splenium. Also, the spinal cord hyperintensity is also non-specific finding, because we usually don't screen the brain for various hypomyelinating disorders. So it is not sure if they can present with hyperintensities or not, since we don't screen the spine usually.
Yeah, I think this classification of hypomyelinating leukodystrophies is evolving. Some of the condition in polymerase deficiencies, the white matter abnormalities are not at all prominent. Very subtle white matter changes, and more of basal ganglia involvement is seen. Even Paul R3 also, they although categorize it on OMM as hypomyelinating leukodystrophy, but hardly any white matter changes.
I think there is a dystonia phenotype, if I'm not mistaken.
Correct.
Yeah.
Next question for Dr. Ramesh. As a clinician, how will you approach and evaluate a child with a suspecting leukodystrophies or a hypomyelinating leukodisorders? So what are the clinical clues you look at, and how do you manage the genetic workup?
Yeah. I think the presentation, if you look at the hypomyelinating disorders, it's very not very characteristic in terms of clinical pointers. Most of them in infancy, they present with developmental delay and hypotonia, central hypotonia. Some of them may be so hypotonic that they may be actually evaluated for neuromuscular disorders initially. But important clue is they have good anti-gravity movements. And some of these children also have nystagmus from birth. Actually, from very early days, parents can tell you this shaky eye movements. And microcephaly is a variable feature. So at least central hypotonia, congenital nystagmus in a globally delayed child with often cerebral vision impairment also. So these are the clues where you can think of a hypomyelinating disorder just purely on clinical grounds. Examination wise, I think we need to look at all the clues, especially the dental clues. Some of them have dysmorphic features, but none of them are strong handles to differentiate. So following MRI, I think pattern recognition is the crucial part before we narrow down to which group of white matter disorders we are going to characterize. Clinically, of course, the leukodystrophies, the classical leukodystrophies, you will have a more rapidly progressive course, whereas hypomyelinating disorders tend to, initial few years, they behave like a static disease, but over later part of the childhood, even they stagnate or even regress also. So that's the usual pattern as opposed to the classical leukodystrophies like metachromatic or Krabbe disease. The genetics, I think the most feasible thing would be to do next generation sequencing, either a whole exome or a clinical exome. Biochemical, I think treatable disorders, probably the homocysteine metabolic disorders should always be ruled out. Maybe you can comment more on that. We have a lot of experience with that. Treatable conditions with white matter abnormalities primarily. Dr. Sangeeta.
Yeah. Most of the hypohomocystinemia disorders, they present with like a dysmyelinating rather than a delayed myelination. That's what the observation we have found in our cohort. Dr. Nihal, do you find hypomyelination as a common finding in hypohomocystinemia disorders?
So homocystinemia, what we usually find is the diffusion pattern is they usually demonstrate confluent abnormality or diffusion restriction. And the flare and T1 is usually more hypointense in comparison to a typically a hypomyelinating related disorder. So diffusion can help in differentiating the diagnosis. And again, the hyperintensity and the hypointensity is slightly different from a typical PMD type hypomyelinating disorder.
Sure.
Even biotinidase deficiency untreated, they can have significant delayed myelination in early life. Yeah. I think those two are the treatable ones that comes to my mind when you think of primarily white matter diseases.
The thyroid related, I think, MCT8 also mentioned.
One of the participant has asked, can you please repeat the normal myelination MRI?
From this side. Geeta, maybe go to the first slide. One before that. Yeah. So this is again on top we have the T1 weighted sequences and on bottom the T2 weighted sequences. So at birth, because the brain is unmyelinated, that it has more water content than fat content because the oligodendrocytes primarily form the myelin sheath. So the oligodendrocytes are the majority of component is fat. So fat on T1 weighted sequences is hyperintense. So a completely myelinated brain should have more fat content in the myelin. That is, it demonstrates T1 hyperintensity. On the left, you can see that the T1 weighted sequences, the white matter is hypointense in comparison to the cortex adjacent to it. Whereas on the T2 weighted sequences, it is opposite, that it is hyperintense in comparison to the cortex and the deep brain nuclei next to it. As the child myelinates, as there is oligodendrocyte formation and formation of the myelin sheaths, there is the signal changes from hypointensity on the T1 weighted sequences to T1 hyperintensity. So T1 hyperintense signal picks up fat faster than the T2 weighted signal. That is why the myelination is faster on the T1 weighted sequences. So at around 10 to 12 months of age, you must appreciate the white matter as a completely hyperintense focus on the T1 weighted sequences, as demonstrated on the last two images on the top panel. If you compare that to the cortex in the deep brain nuclei, which is isointense, the white matter is brighter than the cortex, the gray matter. So that is how you term it as complete myelination or myelination has been attained. Whereas on the T2 weighted sequences, it is predominantly dependent upon the water signal. So the myelin catch-up is slightly delayed as compared to the T1 weighted signal. So around 2 to 2.5 years of age, exactly opposite to the signal on the T1 weighted sequences, the white matter should be hypointense. So around 2 to 2.5 years of age, you can appreciate that the white matter is hypointense in comparison to the cortex and the deep brain nuclei. That is the gray matter. Next slide, Geeta. Next one. Next. So as a rule of hand, just one must think that the formation of myelination progress takes place from the center to periphery. That is, the central structures of the brain myelinate first in compared to the peripheral structures, that is subcortical white matter. It takes place on the back to front, that is the occipital or the cerebellar hemisphere in comparison to the frontal hemisphere. And it takes place on the bottom to top, that is the structures in the bottom myelinate faster than the structures on the top. The myelin clock can be kept in mind, but you can usually have references in literature with demonstrating structures myelinated at each month or each week. So that can be referred. So one must keep in mind the signal changes on T1 and T2 weighted sequences.
How do you differentiate HCC and 4H radiologically?
So HCC presents again with diffuse hypomyelination, but there is some neurodegenerative component later in the further stages. So there will be usually reduction of the gray matter structures and also some variant degeneration. But other than that, it is only a primary hypomyelinating disorder, whereas in 4H leukodystrophy, as you can see in the second panel, the top and bottom rows, the deep brain nuclei and the dentate nuclei are usually hypointense on the T2 weighted sequences. So this is not seen in HCC, and cerebellar atrophy is more common in or earlier presentation in 4H leukodystrophy, whereas in comparison to the HCC. So cerebellar atrophy is another early feature of 4H leukodystrophy in comparison to HCC.
How often do you see hypomyelination or delayed myelination in patients with mitochondrial disorders? How to exclude mitochondrial disorder when you find an hypomyelination on MRI?
Mitochondrial disorders, we don't find hypomyelination. We find demyelination or intramyelinic edema. If you have glucodystrophy type pattern, they usually it is more hyperintense as compared to the ones at least we are seeing now on the 4H leukodystrophy pattern. And on the flare and the T1, they're usually more hypointense, and they have some areas of restricted diffusion. If it is a cavitatory leukodystrophy, then peripheral areas demonstrate restricted diffusion. And the corpus callosum is also another important marker for the mitochondrial disorder. That is, the middle bed of the corpus callosum is predominantly involved in the mitochondrial disorders, whereas it is diffusely involved in the hypomyelinating disorder. And obviously, lactate peak is helpful in the normal and the abnormal brain.
Sure. When you see in neonates, you'll find that subtle hyperintensity of the dentate nuclei, and even if you see the globus pallidus also on T2 weighted images, you will find subtle hyperintensity.
Yeah.
So till what age can you take that as a normal and pass it off as normal?
At around the globus pallidus at around 10 months, up to 10 months is more hyperintense in comparison to the putamen. So after 10 months of age, it becomes isointense. That is, the mineral deposition takes place. So up to 10 months, if there is no restrictive diffusion, associated restrictive diffusion or volume loss, then one must take it as normal. But if you see hyperintensity with some degree of volume loss, then one must think of kernicterus. If there is restrictive diffusion, then inborn errors of metabolism. The dentate nuclei up to 12 months to 18 months is slightly hyperintense. There is a reference article which demonstrates the dentate nuclei changes. At around 2 years of age, it is almost isointense, but up to 18 months or so, there are still some hyperintensities in the dentate nuclei.
Sure. I think there are no more questions. Any more comments, Dr. Ramesh, you want to make?
No, I think that's all very well clarified. A lot of differentiating, very finer differentiating points were clarified by Dr. Nihal.
Yeah.
Thank you.
Thank you so much, Dr. Nihal, for the excellent discussion and teaching us a systematic approach. And thank you, Dr. Ramesh, for the nice selection of interesting set of cases and guiding the residents. And appreciation to Dr. Dibankana, Dr. Bhavan, and Dr. Geeta and Prutuja for excellent presentation. Thank you all.
Thank you.
Thank you.
Thank you.
Thank you, everyone.
Thank you.
Thank
Bye-bye.
you.
Bye.
Bye.